introduce the other members of the Fresh Benny's team here that are on the call with you. So we've got Mandy Baker, who is our fabulous account executive. Mandy, if you can give a wave just so we all know who we are. And then it's also my pleasure to introduce our CEO and co-founder, Reed Rasmussen. I know a lot of you are familiar with Reed, but having worked incredibly closely with Reed for the last 3 years, not only are we both from Canada and share the same birthday and have married better halves who are short-haired blonde, Reed, one of the things that really sticks out is Reed has an infectious enthusiasm, and he also loves to educate. And so over the course of the next 29 minutes, I think you'll find that Reed is going to be able to walk you through not just the issues, but how you can help take action and be better prepared for this shifting landscape that we're all dealing with for 2021 and beyond. So Reed, I will pass it over to you.
Awesome. Yeah, we're going to talk about 3 ledge issues that you can't ignore this year. And we're going to talk through commission transparency, public option, and provider transparency. And these are all 3 areas that are in the gray area. They're issues that are being sorted out and the rules are being figured out. And so they're not exactly clear cut. So what we did was we went to pull in some guest faculty, and we got opinions from a wide variety of folks. And we, between the 3 of us, we did hours of research with them to pull down a half-an-hour powerhouse session. So we're going to plow through this today. We've got Eric Bricker, who's a physician. He started Compass, which today has rolled into Alight. That's our advocacy vendor. He is a great educator and owns a company called A Healthcare Z. Marcy Buckner is the Senior Vice President of Government Affairs at NAHU. Jay Booth is a broker out of Virginia with Capital Group Benefits. Great insight. David Smith, he trained as a lawyer. He lives today as a broker with eBen Concepts. Josh Butler is a broker who 3 years ago turned his philosophy into being transparent on his commission. So we've got some comments from him. And Dane Reinhardt is a broker with TriBridge Partners in Maryland, but he also happens to be this year's NAHU president. So you know who we are. Let's start by jumping to a poll. And here, I'm going to pull up the poll and launch this. If you'll answer this here, and just be quick on answering this, this is multiple choice, but what type of clients do you serve? Do you serve large group, those of 100 plus? Do you serve small group, below 100? Do you serve individual and Medicare? And maybe some of you do some other kind of business as well. We'll give it a second. We've got about 50,000 people on the webinar today. So we're sitting at about 40,000 that have answered so far. So we'll give it a couple more seconds and we will end the poll and share the results here. So what you're seeing is 54% of you sell some large group. Almost all of you, 85%, 84% sell small group. Half of you sell individual Medicare and a little bit of other in there. Okay. So that's fair. We'll stop sharing that and go on to the next slide. Good. Okay. So why are we going to talk about current events that are so current that they're still in the gray area? And Dane has a great insight on this.
If we don't have some sort of email or communication with our clients about it, 14 other brokers are emailing our clients right now because they're prospects. And they're like, how come you didn't tell us about this thing that happened 11 minutes ago? I was like, damn it, we missed it by a minute. Like, it's an arms race too. But I will say, when you can get a prospect or a client to do this, everything changes. If you can just be like, hey man, let's just talk.
I love that. Yeah, let's just talk. So let's get you conversant on these topics, okay? So the first one is commission transparency. The Consolidated Appropriations Act of 2021 was actually signed into law on December 27th of this last year. And amongst the 5,593 pages of that act, there was a section that said brokers need to disclose all compensation. Now, they said it means direct and indirect compensation, anything that's $1,000 or more, even if it's small group or individual, which is interesting. That's certainly a change. And that you need to disclose it at the time of sale and at renewal. And, you know, there's a lot in there. Jay here does a great job of expressing the confusion around this.
What does that mean? Does that mean I have to draft a memo on letterhead and itemize everything all my commissions on every product in that group, including percentage of bonuses from an ancillary carrier or a medical carrier. Well, if that's what we need to do, then we'll do it. But that kind of bums me out a little bit because I think, what an utter waste of time. Really a focus on the larger group in this conversation, but think about the small group. Any commission over $1,000 is the way the law is written as it sits today.
Right.
So we had a lot of groups that are smaller. We make $1,000 a year. That's $83.33 a month commission.
Yeah.
That's small group.
Right.
Yeah. Well, let's jump to a poll here. And on this next poll, let's ask the question of what you do for disclosing your
What does that mean?
commissions.
Does that mean I
Oops.
have to draft a memo on
Excuse me
letterhead and itemize it?
There we are. Okay, so we're on the poll. Do you currently disclose your commissions to clients? And this one's one choice only. 100% of the time, most of the time, only some of the time, or never. Let's see what we've got here. A couple more seconds. I know some of you, you're like, most of the time, is it only some of the time? What we see here is that 25% of you are disclosing 100% of the time. That's fantastic. And a high number for most brokers, I think. 14% of you disclose most of the time. 39% say only some of the time, and 22% say never. So there we are on that. Good, we'll close that up. Okay, well, Marcy does a good job here. You know, some of you are saying, hey man, we already do 5,500s, but okay, so a law has passed, but there's a life cycle of the law then making its way into the rules. And Marcy does a great job of describing how that goes about.
So there was a piece in the Consolidated Appropriations Act of 2021, which I know everyone has memorized and they know exactly what that is. But there was a section in that required agents and brokers to disclose all direct and indirect compensation and commissions that they're earning. And this now is going to rulemaking. So what we have is the very broad what they have to do. They have to disclose their commissions on individual, small, and large group markets. What we don't have yet is the how exactly they're going to do it. This is now going to the rules, so to the agencies, to HHS and the Department of Labor, Treasury. Is trying to say Department of Labor and Treasury at the same time, but it doesn't work. Department of Labor, Treasury, HHS. And so they're going to write the rules on exactly how this happens. What NEHU is doing right now is we're putting together what we're kind of calling our guiding principles about what you all are already doing on the individual side, on the group side with 5,500s, with your even just the standard business practice of disclosures that you're already doing. We're putting all of this together so we can bring it to them and say, this is what's already happening. If you're going to implement this law that passed at the end of 2020, we would like you to do it as closely as possible to what agents and brokers are already doing, so that this won't be very burdensome. It will be something that you'll be able to incorporate into your business practice, similar to what you're already doing. And so those rules are likely to come out this summer. They'll go through a comment period. We'll get the final rules later in the fall. We will do a lot of education about what those final rules are and what that requires of you. And then it goes in place December 27th of 2021 on a rolling basis as your contracts renew.
I always love hearing how these laws actually get implemented. And Marcy did a great job there of summarizing that. And effectively, it's complicated and it's going to take some time. But for those of you that have not yet transitioned, Josh does a great job of describing how he did that in his agency 3 years ago.
Were there any things that you did in advance to kind of prepare yourself for having different conversations?
It's gut check. It's a self kind of analysis exercise to say, look, because let's be honest, Neil, brokers and consultants and advisors in this industry, they make a lot of money. It's awkward in the beginning when you first start disclosing your revenue. But most times, more than not, they say, wow, that's all you make. It's not, oh my gosh, you make so much. Every year, at least one time a year, they're getting a document in writing that illustrates our level of revenue. And then they sign it and we sign it. It becomes part of the documents that we preserve.
The documentation on a yearly basis. That's really interesting. And did you guys create that commission disclosure form, or where did you get it?
No, so the actual form, I mean, we have our own version of it now. Health Rosetta had a comprehensive version of it where it goes and where you can list every carrier, every line of coverage.
And what we'll do is we'll include in the email follow-up with the other resources, a link to that Health Rosetta form, so that you can, for those of you that haven't done it, and most of you have not yet started disclosing from what our stats said, but, Dane expresses that question that might be on some of your minds.
I do think that for certain brokers and certain clients at certain brokers, it is going to be something you're going to need to discuss with them, and it will be a little bit eye-opening. I mean, we have moved towards stewardship reports with all our clients, so we discuss everything with them. But I do think that there are brokers that do a good job that are going to just be like, yeah, that one LTD case I wrote with a 20% commission that renewed and they grew by 300% kind of thing. You're like, ooh, I'm now making way more than I was on that. I haven't had that discussion. So just stuff like that.
Yeah. And Josh goes on to talk mindset.
Is there anything that you would recommend as far as, resources or just how to really get into that mindset of becoming 100% transparent?
Well, my advice would be this, is not to bucket, don't try to swim against this tide, because the tide is going to overwhelm you if you don't get on board with transparency, because everything's moving in that direction. My advice would be to get on board and support it.
Yeah. And so that's the section on commission transparency. And what we're going to do at the end of each of these sections is actually just sort of summarize, what can you actually do about this? So our 3 tips for you are: 1, start tracking the work and the hours and the number of calls spent with every single client. Will help you in this process. Track all sources of income, bonuses, etc., and try to think about it down to the client level. And then 3rd, don't wait to have the client conversations. I know some of you aren't there yet. You're not like, well, I don't have that full form filled out. Everybody who went through this gave us the advice of start to have that conversation. Just start to talk about money and the fact that you actually make money in your business, which isn't a surprise, but it's a big hurdle to get over. Okay, so for our second topic, we're going to talk about the public option. And various bills, there were 4 big bills that had come out over the last 4 years that promoted a public option plan. And another one passed this last week. They're starting to gain a ton of support. And it used to be Medicare for all over the last few years was the big push. Now public option is becoming the big push. And we hear all these different terms. We had the Affordable Care Act, universal health care, Medicare for all, single payer now. Down in the left here under this mass of names that get thrown around for different ways to organize healthcare is the public option. And on the surface, people on all sides of the aisles and all Americans want to say, hey, that sounds like a decent idea because I love freedom as an American citizen, right? And if I love freedom, then I must love options. It's just an option. It's great marketing is really what it is. But let's go and have Marcy actually describe the mass of different public option opinions and ideas are.
So there are different ways a public option could be set up. So the kind of simple way is that there would be a public market that would run alongside the exchanges, Medicare, the private market. And in this public option, it would be government negotiated rates that are available through the public option. And there are different, so this is where we get the different variations. There are different variations where this public option market would be available for everyone. There are options where it would be available for a certain age group. So possibly taking the higher end of non-Medicare. So the 50 to 65, allowing them to go into a public option. There are also different proposals that would allow small groups to go into the public option to try to lower their premiums even more.
And if you heard it in amongst the things she was saying, what she was saying is, yeah, it is complicated. So let me give you one example that you can get your head wrapped around on this picture. Let's say in your state that you've got an exchange that sells to the individuals. And you've got a number of carriers that sell outside the exchange, they sell inside the exchange. Then you've also got some carriers who they sell individual and of course group business completely outside of the exchange. And so depending upon your business, you might say, yeah, I'm pro public option. What do I care if there's another option to be sold inside the exchange that happens to be a government designed healthcare plan? Well, here's why. And that is that the key difference between these is the way that they contract with providers and hospitals, because the BUCAs of the world and the health plans, they have to contract separately with each provider and hospital. What the public options all go with is we are going to force providers and hospitals that if they're going to do any business at all with Medicare and Medicaid, that they have to accept these pricings. And so what it does is you've got this, it will bring some instability to the provider income base because they have to have private health insurance that pays at the levels that it does to balance out the Medicare and Medicaid pricing, especially in rural areas. And so if this ends up destabilizing the market and taking over the exchanges and the individual plans, it has the ability to be a risk to the entire market, and it's a path to single payer. Now, the way this is going to play out in the next couple of years, at the moment, while there are bills at a federal level, it's not likely to pass at a federal level. Where we're going to see this bubbling up and really the biggest threat is at the state level.
Yes. So Washington, like I said, they're in their first year of trying to phase this in. Colorado is another one that's playing between a single payer and a public option. They have defeated just a couple of years ago a ballot initiative in Colorado. So their citizens said no, thank you to a single payer system within their state, and now they're trying to look at a public option. Connecticut is another one. California is a wild card. They have a few different things that are going on there, but New York is another state that's tried to introduce something. There are, I think, 21 states in total that have introduced something that is either a single payer or a public option. Really, 4 or 5 of those are going to be battleground states. Illinois is another.
Did you hear what she said? Half of the states have some bills coming up on this. And so far they haven't. You also heard her say that Washington State has already had a law on this and a production, and it hasn't gone all that well. David talks about that.
I think we're going to see some come through. I think this is a good example of sloganism versus implementation. The way it's implemented is not a all provider network. So in Washington and Colorado and other states that have done this, it really is a Medicare Advantage option. And so, yeah, you can buy this product and it's cheaper, but the network's like this big and the drugs are this list of drugs. And if you don't fall within that, well, then it doesn't do you any good.
So this will come through a lot of different iterations, but the issues to focus in on when you watch this over the next few years is that public options, they bring in market disruption, pricing issues. The providers and hospitals get buried in Medicare and Medicaid prices, and especially it's going to be tough in rural areas. So a lot is yet to happen. But as we look to the public options and what can you actually do about this right now? Well, one is take NAHU's Medicare for All certification course. It's not to teach you how to build a Medicare for All. It's how to understand how nationalized systems have worked in Canada and other countries around the world. This is a 3-hour certification class. A piece of it is about public options. I actually teach this class. You can find it, it's available online these days. You can respond to NAHU's Operation Shouts. And if you are part of NAHU and you know what that is, then fantastic. If not, I'll send you a link to this in the resources. And Operation Shout is that NAHU does the work to give you a link, click through it. It's kind of fun to see it the first time. Click through, you put in your home address, and it'll tell you who your representatives in Congress are. And then it will auto prep some emails to go to them to explain why you don't like a topic like this. So it's a very simple way to let them know in an educated way why a public option is going to destabilize the market. So get involved in those, and then don't ignore this. You know, it's something we have to talk to our clients about. So that's it for the public option. Number 3 here is provider transparency. And there was a regulation from CMS January 1st, 2021. And CMS said, listen, we've had these rules about hospitals, you need to be transparent. You've been kind of bucking the system a little bit, putting up these charge masters that people can't even read. You need to provide to start posting. In January, they said that this went into effect. You need to start posting for every for all your services that we're about to identify, what the build rate is, like what's the high retail price, what's the minimum and maximum amongst all your carriers, what's the one minimum and then the one maximum charge, what's the cash rate you would charge somebody for it, and what are the carrier specific rates by every carrier. It's pretty significant, right? And then what did they need to post that for? For what they defined as 300 shoppable services. 70 of those are specifically defined by CMS. And like 13 of them were medical surgical. They were things like cataracts, colonoscopies, joint replacements. 13 were evaluation and management codes. 14 were labs. 13 were radiology. And then for the other 230 items, they said, just put up whatever you want. Well, if the whole goal here is to be able to compare one facility versus another, those 230 are basically going to be useless, right? If you're a hospital, you'd probably put 230 different lab codes up there, but you're going to put up stuff that's different than all the other hospitals, right? So the interesting thing was seeing how this is getting posted. And Eric Bricker found one hospital in Florida in January, and he talked about what he saw when he dove into the file.
Attention, the Baptist Health South Florida hospital system in the Miami, Coral Gables, Boca Raton area, because they actually have a file. I'll leave a link in the show notes to the website so you can look at it, right? It's a 141 megabit file. It has 62,000 rows on it. It's an Excel file, right? And then there's 90 tabs. And it's a little misleading because 45 of the tabs are for outpatient and 45 of the tabs are for inpatient. So it's really like 45 tabs. And then those 45 tabs are broken down by Aetna, Blue Cross United, Cigna, PHCS, Health, First Health. And then it has like the different sort of networks or contracts that they would have, right?
Yeah. And some of the hospitals have this up and rolling. And they said, you've got to post this file or else. And you say, okay, well, or else what, Reed? Or else we're going to fine you $300 a day. And I say it that way because $300 a day would be a big issue for any of us on the call. But quite honestly, if you're a hospital and the kinds of budgets they have, there's a lot of hospitals who they'll do one more surgery and make up that fine. Like that is not that's a slap on the wrist is all that is. The bigger thing is that they would be on CMS's blacklist for not being a transparent hospital. It was interesting. So this rule went in January. All it took was until this week for the Wall Street Journal to come out with an article, hospitals hide pricing data from search results. So it's not that they just didn't have it on the homepage. They literally are finding that most of the hospitals, they're actually coding their website completely different from everything else they do on their website, where it's coded to stop Google from ever finding it. And this last weekend, I was looking in Dallas. I was trying to find one hospital in Dallas that had the file posted like Eric had spoken about. I couldn't find one. What I did finally find was there was Baylor Scott and White. They have a rehab clinic. So they just had a few of the items posted. It was hundreds of lines, not 62,000 like he showed. But when you look at this, you're like, is Joe or Mary really going to be able to tell where's a great place to get a colonoscopy? Is it this facility or that facility with this kind of data? And the truth is, it's tough for the layman to find it. It was interesting. Eric went on to describe as he dove into the file, and somebody with his expertise, what he found.
Right, so MRI of the lumbar spine without IV contrast, very shoppable service, chronic low back pain, need to go in and see if you got a slip disc or spinal stenosis, etc. Super common, super shoppable. Don't ever tell me this is not shoppable. Okay, 72148 is the CPT code. It's almost always done without contrast. You don't need to worry about the whole contrast thing, right? So look up the file. For Aetna, they've got bill charges of $4,627. They got a minimum allowed amount of $1,665. They don't have to say who that's to. They just have to say that's the minimum. They got a max allowed amount of $4,164. They got a cash price of $3,007. And then the payer specific for Aetna is for their HMO, their allowed amount is $2,359. And then their allowed amount for the PPO plan is $3,701. And that kind of makes sense, right? Because of steerage, the hospital is more likely to give them a better allowed amount than the PPO, where they can't do any steerage to them. So it makes sense that the PPO rate is higher than the HMO rate. And a couple other interesting things. Look, the cash price is less than the PPO rate. So they give people cash deals that are better than the Aetna deal. Okay. Now, if you go through the other payer tabs, Cigna, Blue Cross, United, of course, the bill charges, min, max, and cash prices are all the same in those fields. And they are, right? You would expect that to be pretty consistent. However, for Cigna, the HMO, for the payer-specific one, says NA. It does not give the allowed amount for the Cigna HMO. Gives it for the PPO. PPO is $3,701, same as the Aetna amount. In other words, this hospital system gives the Aetna PPO and the Cigna PPO the same deal. They give them the same allowed amount. Then things get real interesting when we get to Blue Cross and United, which are arguably in Florida Blue is huge. It's the 800-pound gorilla. And then from a national contracting perspective, United is the other 800-pound gorilla nationwide. Again, same for bill, min, max, and cash for Blue Cross and United. Now for Blue Cross and EG, they don't give any Blue Cross allowed amount information. None. Next, for United, same bill, min, max, cash, right? Consistent. United, they don't give any allowed amount information for United. I scratched my head. It's kind of weird.
It is kind of weird. And why would they do that? Because those are their most proprietary, that's their best rates. They're struggling, they're fighting with this. Even if you could find the file, there's times they're going to not even fill in some of the fields because they're choosing not to. I asked David, is this data in a format that's really going to help consumers?
My honest perspective is that it's probably a waste of the time for the traditional consumer, and for two reasons. The first of which is because I think it's still set up to be so complex that the average consumer, or even the above average consumer, is going to have a hard time going online and figuring out what they're getting, what they're paying, and all the network contracts.
And Jay went on to summarize our desires for consumerism.
The dream is to have complete and utter transparency, that we can walk in almost like a deli. If I want a turkey sandwich and it's $6.95, or I want a roast beef and it's $8.95, does it come with a side of chips? Does it come with a pickle? I know everything about it. Oh, I can add a cookie for 99 cents. Great, I'm in. That's consumerism.
Right.
And, when you think about what our clients are really begging for, like my reference, I said, a couple of years ago, I needed a colonoscopy. Like, if I came to this data, if I'm Eric Bricker, I can figure my way through this to be able to compare facilities, but is Reed Rasmussen going to do that? Probably not. And shameless plug here, guys. Inside Fresh Benny's, we have an advocacy service. We use Alight. It's actually the company that Eric's company is behind. And when I did ask this question of needing a colonoscopy, they were able to say, okay, on your plan in McKinney, Texas, available for surgery, here's the estimated costs, here's the highest caliber companies, here's what you want. And it's the difference between figuring stuff out on your own on your computer or walking up to the Genius Bar. If you're looking for a Genius Bar for your clients, and that's what most really want when it comes to healthcare, this is really where you're going to find it. So on provider transparency, what can you actually do? Discuss transparency with clients because it's hitting the newspapers. So people are even more interested in it. Stop asking your own team to investigate pricing. Thinking that this is something that's fairly simple. The number of questions that are coming today on this are higher than ever before as those out-of-pocket costs go up. And yeah, I said shameless plug. Hey, if you want to outsource to us for a premium advocacy service, we'd be glad to serve you. If you already have another solution, fantastic. But here's the deal. I don't think any clients are going to be happy with their broker or their experience in benefits without a premium advocacy service. So what we'll do is we're going to go to the last poll here. Let me pull this up. Poll number 3. So for you guys, would you like more information on Fresh Benny's? No, I'm good as a financer. But if you want, this is a multiple choice. So if you want some info on advocacy and transparency services. We'll be happy to get that for you. If you'd like some, we are launching a new large group product. So if what you want is for large groups specifically, so groups at 200 plus, if you just want an advocacy service, we've created a product that's just for that. If you just want a telehealth service, we've created a product just for that. So that is going to officially launch in April, but I'm gonna share the info with you if you want it in advance. Okay. So there we are. Thanks for that, guys. We'll end the poll there. And if you had any questions, by all means, let's tap them in here. As far as takeaways today, I would say study and share the follow-up resources we're going to send. There'd be a lot because we'll pull all the stuff that people had referenced here today. Stay informed and involved. Join NAHU if you're not a member, because they're representing us as an industry well in Washington, D.C. And then for you guys, chat in the Q&A. Tell us what stood out to you today. What can we do for other training sessions for you? Or what questions do you have? And maybe, Neil, maybe I've 1 minute for one question.
Yeah, we had a bunch come in, and for those of you that were asking questions, we'll be sure to share the additional Q&A in our response next week. I think one of the big questions was how to build the actual disclosure form. That's a couple people had asked about that. So we will share a specific example in our follow-up email next week and give you some guidance on that. There is no standardized form though right now that has been provided. So a lot of people are building their own forms, but we'll give you something that you can use as at least a starting point to work from.
Yeah, it's a good brainstorming form, the sample that we'll send you. Good?
Yeah.
Well, thank you, everybody. I hope these were helpful. I hope this was a helpful format, and all the best, y'all.